So far in the category of anxiety-like disorders, we've talked about anxiety that comes from nowhere and anxiety. We talked about anxiety that comes from some sort of personal stressor, that's like the impulse control, and the stressor that comes from within, that's OCD, its related disorders. We haven't talked about is what happens when you have a massive stressor happen to you once. How does that affect people and what disorders can come out of it? I think most people going through medical school now recognize PTSD as a real problem, a serious thing that happens to more than just World War II and combat vets. Especially in the setting of the Vietnam veterans where we didn't even recognize the fact that this is a disorder, we've really done some disservice to people who have it. And so in the DSM-5, we've made it very easy to qualify for PTSD. And the idea is, the sooner you treat, like debrief right after the stressor, the shorter and less severe the duration. The longer you wait to treat, the more severe the symptoms and the more difficult it is to treat. So we're going to start off with the model in general, and then we're going to spend a lot of time on PTSD and round it out with some of the other disorders that sort of are related to stress. This is the stress-related disorder lesson. And so what happens is someone has some sort of stressor, and that stressor is going to lead to a disorder. The severity and proximity to the stressor determines how severe the disorder is going to be. And by proximity, I mean, does it happen to you or did you see it happen to someone else? If you have a life-threatening, severe stressor, and you don't cope with it, debrief, talk about it, engage in therapy early, the disorder you're going to get is PTSD, or its cousin of shorter duration, acute stress disorder. If the stressor, instead, is non-life-threatening, but is life-changing, it's a big deal, you might end up with adjustment disorder. If you're a kid that's suffering neglect or abuse in infancy, you might end up with the attachment disorders, which are reactive attachment disorder, which is you pair too little, or disinhibited social engagement disorder, which is where you pair too much. We're going to spend a lot of time on PTSD and acute stress disorder because it's very prevalent. It's almost preventable if you debrief. And the sooner you get someone therapy, the better they'll do. And a big problem is that people who have PTSD don't even recognize that they have it. So it's up to us as medical providers to identify it and get it treated as soon as possible. All right, post-traumatic stress disorder. The pathology comes down to the severity of the stressor and then the exposure. The idea is the closer you are to experiencing the stressor, the less severe the stressor needs to be to induce PTSD. The further removed you are from the stressor, the more severe the stressor has to be. If you hear about a girl having her purse stolen last weekend in a state you're not from, you're probably not going to even engage that story. But if you had your purse stolen at gunpoint last weekend, you probably are going to engage a lot more and be at higher risk. It also means that people who witness acts of terror, even through the news, can still succumb to PTSD, even if it didn't happen to them specifically. Certain people are more vulnerable to PTSD than others, but it's a real thing, and so we've made it more inclusive, so more people can get help in case they're suffering the symptoms. All right, let's talk about the stressor itself. The stressor could be actual death, and that's going to obviously be something you witness. It could be threatened death. You see someone almost die or someone almost kills you. Combat is still a big deal. Our veterans who've seen combat are at high risk for PTSD. But survivors of severe events like sexual assault, being raped or almost being raped, kidnapped, can develop PTSD. And then, as we'll discuss, people who are abused or suffer neglect may also be at risk for PTSD-like symptoms. And it doesn't have to be in infancy, like with RAD and DSED. It could just be that you're abandoned, abused, or neglected sexually, emotionally, physically, that leads to PTSD. The exposure also matters. So it could either be experienced or the event happened to you. This is the self. It could be witnessed. It's happening to others. Or it could even simply be learned. You hear about it. That only happens when you're closely tethered to the person it happened to. This is a loved one, family member, spouse. And I like that this one has been added. Repeated exposure of the aftermath. That is, the paramedics weren't there when the bomb went off. The EMTs and the police weren't there when the fire started. But pulling dead bodies out of the building and taking parts of people and trying to put them together in the street, resuscitating people bleeding all over the place and dying, still counts as a major stressor. Even if they don't see a live person and they never even see the building that burned, just the fact that they were there seeing the catastrophe or repeated exposure puts them at risk. But again, in order to count of learning of a loved one, it has to be violent and severe. It can't be you found out that your daughter fell down some stairs. It could be that you found out your daughter was kidnapped and thrown down a flight of 20 stairs and now in the hospital at the ICU. If you get thrown down a flight of stairs after being kidnapped from a military zone, you're at super high risk. See what I mean? The closer to the event you are, the higher the risk you are. The more severe the stressor, the higher risk you are. And so the patient is going to exhibit the disorder. And what does the disorder look like? There are 5 categories, and I'm going to try to parse out each one. We do this in a chart in detail in the notes. There's intrusion, mood change, dissociation, avoidance, and arousal. Intrusion are those things that shouldn't be there but are. Memories, flashbacks, nightmares. Waking up in the middle of the night, pulling out your knife and stabbing the lampshade thinking it's an enemy soldier. Right? Waking up next to your husband and thinking it's the attacker. Mood changes are almost always negative. It is going to be depressed mood. Mood changes in adjustment disorder can be anything, usually depression. But in PTSD, it is almost always depressed mood. They usually don't get thrown into mania. Dissociation is the depersonalization we'll talk about in the dissociation lectures. Avoidance is going to be literally avoiding, like not going to the place where it happened, not looking at symbols, not even talking about it, which is dangerous because, as we'll see, that's the mainstay of therapy. And arousal is hypervigilance, irritability, always looking over your shoulder, always being aware of your surroundings and never being able to calm down. That's not anxiety because they're going to be depressed, but it's hypervigilance. The diagnosis is clinical. And the emphasis is on ruling people in, getting them the therapy they need. Once you've made the diagnosis, once they have enough of the disorder checked off, you then look at the duration. If the duration has been more than 3 days, but less than 6 months, they have acute stress disorder. If they've had the symptoms for more than 6 months, and onset was after 3 days, they have full-blown post-traumatic stress disorder. Nothing happens at 6 months. No switch is flipped. But the idea behind this is that if you engage early and the symptoms start sooner, it's normal. If you almost died, you're supposed to be freaked out. And if you talk about it, debrief, and engage it, you may never even develop acute stress disorder. If you get to these patients sooner in the acute stress disorder phase, the treatment duration and the severity of the disease will go down. If you wait after 6 months, and 6 months is relatively arbitrary, but it still says if you wait too long to get engaged, to do the work, to solve the problem, it's going to be harder and longer to do. And the treatment, see the parallel, this is a chronic anxiety disorder, so much like generalized anxiety disorder. From our anxiety lecture, psychotherapy is the best thing to do. And psychotherapy here comes in the way of group therapy, survivor groups, talking about what happened to you with other people who understand, which is problematic because some people may avoid talking about it altogether, which will decrease the chances that they'll get better. It's a chronic anxiety disorder, so SSRIs, SNRIs, not surprisingly, are the adjunct therapy. And if they have panic attacks, you can use benzos. But what I want you to learn is that you do not treat anxiety disorders with benzodiazepines. Only panic attacks get treated with benzos. They're habit-forming and addictive. And the problem is PTSD patients may not even know they have it. And if they have it, there's still a stigma against it, so they may not seek care. Instead, they may end up with full-blown mood disorders on top of it and substance abuse as they try to treat it themselves. The emphasis on this talk is to show you anything can happen to anyone and it will count. If they have the symptoms of PTSD, engage and treat them earlier so that the symptoms don't persist. And the higher someone is for risk of developing PTSD, the earlier you need to intervene and the more aggressive you need to be to screen them. All right, let's go on to some easier ones. That was the long one. That's most of the lesson. Let's talk now about the kid diseases, reactive attachment disorder, disinhibited social engagement disorder. The stressor is some abuse or neglect that happens in infancy. And this may come in the way of an absentee parent, right? The kid cries, no one comes, sits in a wet diaper and doesn't get changed for a long time. But it could also be institutionalized care where the kid is bouncing around in foster care and never really forms a good pair attachment. The disorder can be one of two spectrums. If they develop the disorder, they may develop reactive attachment disorder, where the kid pairs too little. And never forming that attachment, they never form the emotional bonds, they go through life lonely, and generally then begin to suffer from depression. The opposite spectrum, disinhibited social engagement disorder, is where they pair too much. There's no differentiating a stranger from someone you've known a long time. These bizarre social interactions which are going to lead to problems with social interactions in the future. These are the people who got abused as children and now don't know how to be a lover because they either are completely detached or overly bonding to everybody and latch on too quickly. The diagnosis must be made in less than 5 years old. And when you do it, since the symptoms are going to be odd social behaviors, you have to rule out autism. We have a whole section on autism in the pediatric neurodevelopmental section, so I'm not going to dwell on it here since we spent so much time on PTSD. Check out that lesson. The problem is that once the kid has it, it's really hard to get them out of it because through the developmental period, they didn't get what they needed, so they don't have the ability now to form those connections. So what the treatment comes down to is actually targeted at the caregiver. Right? Teach them how to parent better. Give them the resources with which to parent. And if they can't, get the kid to a place where someone can do it for them. The problem is that once you have it, hard to undo. And because either you get dumped a lot or you never actually pair to begin with, kids are lonely and they feel it. And so they're going to end up with mood disorders like major depression, anxiety, and substance abuse, as they use substances as a substitute or to treat their mood disorder. And lastly, when it comes to the kids, yeah, you ruled out autism, but don't forget about learning disability. These kids may not be able to engage quite as well. You might think they have a learning disability when really it's more of a stress reaction. and they may need specialized tutoring or training in order to become normal in the rest of society. The easiest one is saved for last, that is adjustment disorder. This is the waste paper basket. Right? You have some stressor that's non-life-threatening, which means it's not PTSD. And then the disorder is some mood change, but you don't quite make the diagnosis of a mood disorder. And you can check out the mood disorder lessons, like depression and anxiety. This is sort of like what we talk about in mood 2 with grief, bereavement, and depression. A big life event happens. You lose a job, you move to a new place, your wife leaves you, a child dies. It's a major stressor, but it's non-life-threatening. It's okay to be a little down, to have some mood changes. Usually, it's in the way of depressed. But you may react differently. And the fact that there is a mood disorder that doesn't meet another mood disorder, and there's no psychosis, means you have adjustment disorder. It's related to the onset of the stressor. It's just not that bad. And the diagnosis is going to require time frame. The onset must be within 3 months of the non-life-threatening stressor. And the duration cannot be longer than 6 months. The duration is less than 6 months. If you have somebody with a mood change but doesn't qualify for a mood disorder, specifically no suicidal ideations, no homicidal ideations, because that would put them into full-blown depression, and the onset and duration have not been that long, it means that the disease is not that bad, and you generally don't have to do anything for it. Of course, you can get them into therapy and talk about it so it doesn't progress and convert into something else. But I want you to see that most of this lesson is about PTSD. The closer you are to the stressor, the more likely you are to develop symptoms. The more severe the stressor, the more likely the symptoms. The disorder is a whole bunch of things. Flashbacks, memories, nightmares, depressed mood, depersonalization, avoidance. And the duration is going to determine if you call it acute stress or post-traumatic stress. The key, psychotherapy, adjunct with chronic anxiety meds, and watch out for mood, substance abuse in people who won't admit it. The other two, kids pairing too little or too much, treat the parent, or adjustment disorder, the thing that doesn't fit anything else, pretty easy to remember. That is PTSD and its related disorders.